Okay. So welcome everybody today to our Yale Pulmonary Critical Care and Sleep Medicine Grand Rounds. We are very lucky to be introducing our speaker today. So I'm Ashley Lozier. I'm going to be introducing and moderating our talk today. As if we have Dr. Luke Davis, who is an associate professor in the Department of Epidemiology and Microbiology Diseases, who is also part of our section in pulmonary and critical care medicine. He initially did his undergrad at Princeton and then his MD at Vanderbilt, and then did his internal medicine at Hopkins, then doing his pulmonary critical care at UCSF, where he then stayed on for faculty. He has done extensive global health and public health research in the areas of TB, where he has funding and is involved in multiple societies and administrative positions with regards to his research and positions at Yale. So we are very lucky that he came to us for faculty in 2015, and he's going to be talking to us today on his talk in tuberculosis. So we're happy to welcome Luke.
Thanks so much. It's great to be together with you all. It's hard to believe I've been at Yale for 8 years now almost, and it's been a wonderful time here. It's been a nice opportunity for me to come and be part of the School of Public Health, but I still, in my heart, always feel probably most at home, don't tell my colleagues, in pulmonary critical care medicine, and it's great to be with you today. I'm going to be talking about a topic that I think you'll find very interesting. I'm going to cover a lot of different aspects. It's active TB case finding in high-burden countries, a user-centered approach. And here's the CME information. I have no conflicts to disclose. Okay. Sure. So got 3 kind of ambitious overall learning objectives today. The first is to try to explain what we call the missing millions problem, which is at the root of the global TB pandemic. And then second, I'm going to talk a little bit about this area of human-centered design, which I think is a novel strategy for designing person-centered clinical and public health strategies. And then I'll conclude by talking a little bit about the idea of implementation trials, particularly ones that are pragmatically designed in generating evidence to improve the quality of TB care specifically. But I think this is also a very powerful way of thinking about improving other types of care. And I hope many of you will think about implementation science. I talked last year about implementation science as a tool for addressing health equity in a lot of different settings. And certainly that's going to come out in my talk today. So TB is a global pandemic. It's the leading cause of infectious death. It affects mostly low and middle income countries, particularly countries that have a high burden of HIV in sub-Saharan Africa, countries where there is lots of crowding and a history of lower socioeconomic conditions, especially countries in Asia. And also some countries in Latin America. About 8 countries in the world account for over 80% of cases. And some of those are highlighted on this slide. But I think it's important to remember that TB is not just a problem of low and middle income countries. It's a problem of low and middle income settings. And so there's many countries in the world, including the United States, where there are people who've had a risk factor of being exposed to TB or a medical condition that may put them at risk. And really, we should think about the conditions that are driving that as we're thinking about how we can eliminate TB as a public health problem. Every year in October, the WHO puts together an annual report on the burden of TB around the world. And this is the data from 2021, showing that there are 10.6 million people fell ill with TB. In 2022, which is the most recent data, was a very similar number. And one of the problems that we have in TB is that a large proportion of people do not get diagnosed. It was about 4 million in 2021. A lot of that was related to the public health disruptions of the pandemic. And even in 2022, we're back at where we were for many years before, which is about 1/3 of all people with TB don't get diagnosed. So why do we have these missing millions for tuberculosis, which is a disease which we have diagnostics available, and there is clinical expertise, and there are very good quality and effective treatments. There are really 3 main reasons that I want to talk to you about that are both social and biological. The first is that many people with TB care seek care, but they're not with TB disease, seek care, but are not diagnosed. Second one is that many people with TB have symptoms, but they delay seeking care for a variety of reasons, which I'll go over. And then third, many people with TB actually don't have symptoms. And for that reason, they don't actually seek care, understandably. So the first one, many people with TB seek care but aren't diagnosed, was an area that was of great interest of me when I first started doing this work. As you'll hear a little bit later, a lot of my work has taken place in Uganda, which is in East Africa. And at that time, we were very interested in kind of understanding how TB was managed, because a lot of my work was focused on TB diagnostics. And we set up a study that was based, and you can see kind of a small map there. It's 6 primary health centers scattered around Uganda. This was kind of an interesting collaboration. I think an example that should be modeled in terms of moving just beyond silos in global health. Rather than just focus on TB research only, we were working with colleagues who were doing malaria surveillance and HIV surveillance, and we were able to use a common set of data collection forms to screen a huge number of people who were coming to these health centers to kind of understand the quality of care. And this is really some data from the first quarter of 2009, in which about 15,000 patients presented to these 6 public health clinics. And about 2% or so of those, I guess it'd be 0.2% of those, had cough of 2 more weeks, which the WHO has proposed should be a criteria for evaluating people for active TB. And what we wanted to try to see is that if someone has a risk factor for TB, how often are they being screened, diagnosed, and linked to care? And what you can see is that only 1 in 5, 21%, were actually getting referred for care. Only about 2/3 or 71% completed testing, because remember that testing requires you to go to the laboratory and produce sputum, and actually to come back on additional days to produce multiple specimens. And third, even among those that were smear positive, which at that time was the only way to diagnose TB, only 73% of these folks actually got started on treatment. So these people were wandering around the community with smear positive TB, not getting the benefit of treatment for themselves or for others. And so if you think about each of these steps as a conditional probability, which is something that I think has now entered the public health lexicon, whether you're talking about COVID or HIV, only 11% of the people in that area were getting guideline appropriate care. So knowing that that's a problem of identifying people in health facilities, another problem is that actually many people with TB have symptoms, but actually delay seeking care. So just I'm going to tell you a little bit of a story of a patient. I'm going to call her Rose, who's a 47-year-old woman from rural Uganda, and she's presenting with a very classic sort of symptoms: 2 months of cough, productive of blood-tinged yellow sputum. What we wanted to know was, how long would it take her actually to seek care in a health facility? And so we took advantage of this same system of visits that allowed us to look at 250,000 visits that were happening over a 2-year period to these health facilities. And we knew where these individuals were living to the level of the sub-county, which is a small neighborhood in rural Uganda. And using GIS methods, we were able to map. And what we found is that the median time that people would travel was over an hour. And then you can see in some of the blue areas where black dots are, those are some of the participants attending these public health clinics. The travel time could sometimes be several hours just to go one way. And people will then, because of the long distance to travel, often seek care to reduce travel time, and also because they don't necessarily want to go to these health facilities because of the poor quality of care that I described earlier. So in a study that we just published this last year that was looking at care at regional referral hospitals, shown here on the left, of 1,000 patients, 82% of them had delayed TB care. And we divided that care into kind of 2 categories using definitions that have been widely used to define delays. About 1/3 of people had so-called patient-related delays. We probably might call them person-related delays, or other ways not to blame the patients for them, but meaning that these were individuals who waited more than 21 days to go and seek care. In addition, among those who actually sought care, about 57% of them, it took more than 2 weeks after initial presentation to get their results, get started on treatment, or get told that they had another diagnosis. We also did an interesting thing where we interviewed a subgroup of about 70 participants who had presented to a public health center, had gotten a diagnosis of TB. And we asked them, how did you get here? When did you start out? Where did you go first? Where did you go next? And we created this kind of fascinating map of all the different places that people went. And what we found is that about 80% of people, the first place they went actually did not have any TB diagnostics. So they would go often to a drug shop, which would be near home. Of course, they would end up paying for Robitussin and other treatments that have no impact on the course of the disease. They wouldn't be able to use that money to pay for diagnostics because there were no diagnostics that were available. And then when that failed to resolve their symptoms, they might proceed to other locations like an herbalist or a health post, many of which at that time didn't necessarily have laboratory diagnostics. And all that led to kind of prolonged duration before they finally made it either to a district hospital or a level 4 health center where they could get an actual diagnosis. And all this kind of highlights this cycle that happens with TB. We know that TB arises from poverty because people live in situations where they may be in crowded settings. They may share the air with other individuals who have tuberculosis. There may be poor nutrition and other factors that may drive that. But also the TB diagnostic process itself exerts a huge cost. And fortunately, the global community has recognized that in the last few years, making one of the pillars of TB care not just improving diagnosis, treatment, and prevention, but also preventing the harms that happen. So even though TB diagnosis is nominally free in public health facilities, there's a lot of hidden costs that people have to pay. So some examples of the direct costs you can see over here on the left-hand side. If you think about the cost to a family, the definition of catastrophic costs would be spending more than 20% of your annual household income seeking a TB diagnosis. So just think for yourself what your annual household income is, and imagine spending 20% of it to go to a health facility to get a simple evaluation for tuberculosis. But even a single visit in this study, which was done by some of our colleagues, costs about $10 or about 1% of an annual median household income of $1,000, about $3 a day in Uganda. And a lot of other hidden costs in terms of paying for additional drugs that you might not get for free in a health facility, paying for food for being outside the household, and paying for transportation. Another interesting thing that was identified through this kind of work on catastrophic costs is that about 2/3 of people actually engaged in an activity which we call dis-saving in order to be able to seek diagnosis. And so what that means is dipping into your savings to be able to go and seek diagnostics because you don't have the money on that day to be able to do, or even more seriously, selling an asset, a household asset that has the ability to generate income. So selling a sewing machine or selling a livestock that you might be raising to support your family or to be able to sell when it reaches maturity. So these are kind of some of the reasons why people don't seek care even when they do have symptoms. So the third story I want to tell is a little bit about why people who TB may not have symptoms and don't seek care. And to understand this, we can start with a very interesting resource for kind of understanding this problem, national TB prevalence surveys. So one of the challenges with TB is that because we don't necessarily have low-cost, widely available diagnostics, the standard of care, the reference standard for TB diagnosis would be a series of cultures to confirm whether someone has TB or not. Because those are not affordable on a routine basis, we get very biased data in terms of understanding what the true prevalence is of TB. And so for the last 20 years, population-based samples where you map a population and then randomly select from within those communities and then go and do standardized screening, so screening from door to door for TB symptoms, and then doing chest radiography. And then for those that score positive but have cough, fevers, chills, night sweats, or weight loss, cough of two or more weeks, or have an abnormal chest x-ray, those individuals would get sputum collected for smear microscopy and culture. And in recent years, they'd also get molecular testing done to kind of understand the overall TB prevalence. And what it turns out is that when you look at, and you can see sort of again, the areas of the world where some of these prevalence surveys have happened, but on the right-hand side of this slide, we have in red, we have countries in Africa, and in green, we have countries in Asia. Reading from left to right on the x-axis is the proportion who are actually symptomatic. And the black line down the middle here is about 50%. And you can see the black dots everywhere show what proportion of people actually were symptomatic. Excuse me, those are actually the bars. And the majority of people actually have what we call subclinical TBs. So they have TB that is positive by smear microscopy or by culture, but they don't actually have any symptoms. It's kind of hard to imagine based on the way I guess we've learned about TB, imagining that somebody with cavitary disease for example, with multiple bacilli in their sputum might not have any symptoms, but the prevalence data kind of supports that. So why is that? Well, a couple of kind of interesting pieces of information. We don't know exactly why that is. It probably is advantageous to TB not to give a patient symptoms to allow that bacteria to spread to other hosts and prolong itself in the community. And it kind of fits with what we know about TB evolving with humans over the last several million years. But this interesting study that was carried out in 2016 looked at immune correlates of progression to active TB disease. So the way the study was done was that they took a cohort of adolescents in South Africa that were first enrolled in the mid-2000s at a time period where there really wasn't any national guidelines in South Africa for giving preventive therapy for people who had been exposed to TB or were living in high burden communities or doing any type of screening the way we would here in terms of tuberculin skin testing. And they collected peripheral blood from these individuals and did whole genome expression profiling. And they followed the cohort over a number of years, collecting these samples every 6 months. And at the end of that period of time, they had a number of individuals who were found to have active TB. And they realigned these individuals shown up here in the upper left-hand side so that the red outcome is shown all the way at the right. And what you're looking at is the expression profiles placed on a index from 0 to 100 with genes that are associated with immune response to tuberculosis. You can also see it on this heat map here at the bottom, which shows that as you move from a further time from actually being diagnosed with TB closer, you can see the heat map becoming more and more red. So it kind of changes our notion of TB from something where people have latent TB and active TB to an understanding that this is actually a process where people evolve over time from one condition to another. It's an active process that's going on in the body as shown by this biomarker map. And you can see that if you take this signature, this index, and you can look at this receiver operating curve, the closer you are to diagnosis. So in red, that's from 0 to 180 days. In orange, it's 181 to 360 days. In purple, it's 361 to 540 days, so on and so forth. The closer you get to the upper left-hand corner, which is associated with a larger area under curve and a more prognostic probability that you're going to develop active TB. This is actually a preprint just put out into the literature in July, which is giving a similar story about imaging correlates of active TB disease. So this is a bit of a complex slide, so let me explain what you're seeing. So on the left-hand side, the circles represent individuals from a cohort that was developed of individuals, again in South Africa, who were diagnosed as having been exposed to rifampin-resistant TB. This was done a little bit after the previous study, and now preventive therapy is recommended for people who've been exposed to TB. But for rifampin-resistant TB or drug-resistant TB, it's actually unknown in the literature what the best agents to give. Certainly you don't want to give INH because many of those individuals who are rifampin-resistant will already have INH, or if they do get resistant to INH, they'll have drug-resistant TB. And certainly rifampin is not effective against rifampin-resistant TB. And so what they did is they took these individuals and they screened them with different diagnostic strategies. In the upper part, they used the regular symptom screen according to the South African national guidelines. At the bottom, they proposed this intensive screening algorithm where they're collecting, not only symptom screens, but they're doing chest x-rays, they're doing PET CTs, and they're doing serial sputum cultures to follow people over time. What you can see is that the red dots kind of identify people with culture positive TB that would never be diagnosed with the standard algorithms. And that many of the individuals who started out in the circles progress over time to be found to have active TB when they get screened serially after having been exposed. And I think the nicest images here on the right-hand side, where you can see two patients. The first patient is at the top, the top set, and the second patient is at the bottom set. And you can see these PET CTs kind of describe two individuals who were asymptomatic at month 0. That's what M0 means. One with really not much in the area of activity, the other one with a huge amount of activity, kind of suggesting something along the lines of what we saw before, someone who's likely to have active TB, but is culture negative. And then 12 months, 6 months, and then 12 months. And then about 3 years later, finally, they become culture positive, progressing over this time. So it kind of shows us that TB is not a dichotomous disease. It's a process that's developing We don't fully understand this conversation between the host and pathogen in terms of what's leading to active disease. So in summary, the information that I've shared with you so far is that there's a strong need to think more, not about passive case finding where we stand in a health facility and wait for people to come, because many people who come may not get diagnosed. Those that have symptoms may not choose to seek care because of all the social barriers, and many individuals who have active TB would have no reason to go until they develop symptoms. We need to think earlier about screening people in the community with so-called active case finding or provider-initiated care. And it's very interesting, the NTB strategy that was first put out in 2015 kind of shows that that's really probably critical. If we stay in our health facilities waiting for people to come to us, we're going to be staying on that dotted red line, decreasing about 1.5% per year as the world's population is growing by 2 to 3% per year, meaning that we'll have more and more cases every year. When I first started out, there were less than 10 million cases every year. Now we're almost up to 11 million. So we really need a new approach that's going to accelerate the decline in active TB more quickly. All right, kind of having had that background about the social and biological aspects of TB, I want to move ahead to kind of tell a little story from some of my own research based in Uganda, as I mentioned. Uganda is a country with about 38 million people. It's known for having a high prevalence of both tuberculosis and HIV. About 200 to 300 persons per 100,000 per year develop active TB every year, so about 0.2% of the population, maybe 1 in 400. And because of the high prevalence of HIV, there's a high rate of progression from latent to active TB. And Uganda is known as one of the world's 30 largest countries, countries with the highest burden of TB HIV. At this point, about half of all TB patients have HIV. And about half of those individuals go undiagnosed every year. I've been working in Uganda for almost 20 years now, and a really important part of my work there has been the group at Makerere University at the Uganda National TB and Leprosy Program, which we call the Uganda TB Implementation Research Consortium. And the research that I told you about before, earlier, that I'll tell you about before, is work that I've done together with them. And so we've been talking about active case finding. What is active case finding? Active case finding are strategies of going out into the community to find cases. Probably the best example of this, or the best known example, would be the mass screening campaigns that happened in the 1950s after treatments became available for TB. The first antibiotics became available in the late 1940s and late 1950s. And mass screening campaigns were then undertaken most famously in Alaska, where it led to a rapid decline in the high prevalence of TB among Native communities there, and demonstrated a lot of the principles of TB control in terms of engaging with communities and doing active case finding and treatment. But a less ambitious and probably more feasible approach is TB contact investigation. So TB contact investigation is a WHO-endorsed intervention, of course, where you screen individuals of newly diagnosed individuals with TB. You ask them about individuals with whom they've been in close contact. And close contact is defined by the WHO as having spent one day or night under the same roof as another individual. So about 12 hours of exposure. It's an operational definition that doesn't have a strong level of evidence behind it, but a huge number of studies have been done looking at TB contact investigation going back many, many years. What you can see is that across a wide range of subgroups, the proportion of people with active TB is around 3 to 5%, whether you're looking at any TB disease, whether you're looking at microbiologically confirmed TB, and whether you're looking at low or low middle or upper middle income countries. Even in different age groups, there's very consistent level of tuberculosis that's identified. In addition, a large proportion, probably about half on average, of people who are in a household living with a person that they're in close contact with active TB have been diagnosed with latent TB infection, whether that's by tuberculin skin testing or by an interferon gamma release assay. And on the basis of this, in 2012, and not that long ago, for the first time, WHO recommended that TB contact investigation be done in low and middle income countries. And they recently updated those recommendations in 2021. Now, the evidence that I've shown was a huge number of studies, but most of those were low quality studies. They were studies where researchers went into the community, they screened people without any comparator. And we know that you can find cases in the community, but the question would be, would those individuals have come to the clinic next week or in 2 months, or at a time at which it really wouldn't make a significant impact in terms of public health impact, but yet might be very costly to understand. And there's really only 6 studies in the literature, 2 of which, one from Brazil in 2010 and one from Vietnam in 2018, which showed a significant benefit over usual care, waiting for people to come to health facilities. These were cluster randomized trials that were done in high-burden countries, and individuals were offered screening. And at the end of these several year studies, both studies actually showed a mortality benefit to those who were enrolled in the clusters where active case finding, all-cause mortality decreased in those 2 groups. On the other hand, there have been 4 more recent studies, one that we did in Uganda and 3 others done in South Africa, that did not show any benefit. And so if this is a WHO policy, what is the reason why there's such a big difference? Well, of course, the obvious answer is that it depends on how you implement contact investigation. And this is a study funded by the Stop TB Partnership, the Canadian National Development Fund, done in about 15 countries around the world, looking at the overall coverage at different stages of implementation of contact investigation. So looking at what proportion of individuals who were newly diagnosed of TB were even willing to have the public health service come to their homes and screen their household members. And then how successful was the public health system at identifying those individuals and getting them evaluated. And these large gaps were something that we identified and that we began to study in Uganda around 2015, shortly after WHO began recommending contact investigation to kind of inform national policy and strategies for screening and implementation. Now, if you want to do an implementation study, there's several steps that you go through. One of the first is to try to map what are the behaviors that are in place. So if we're going to do a quality improvement study in the ICU, we want to go and talk with the stakeholders that are working there, the clinicians, the support staff, even the families, to kind of understand how things are done. So same thing for contact investigation. We went to the community, we talked with the different stakeholders, and we found that the steps that were necessary were, of course, screening, testing, diagnosis, treatment, and then following through those individuals, not just initiation of treatment, but also to completion. But what we found is that about 85% of the time when these activities were done, people did not make their way all the way through the cascade. And when we did qualitative interviews, we found same factors that I described to you earlier that were preventing people going to the clinic. The same factors were preventing them to go to the clinic to get screened for a condition that they didn't feel that they had. You know, they'd been exposed to someone in their household that had TB, but for many people, that travel time and cost just were not things that they wanted to take on or they were able to take on. In addition, that same kind of knowledge, lack of knowledge and distrust of the public health system. And so we designed what we call the home-based contact investigation strategy. We said, if people won't come to the clinic, it probably makes sense for us to go to them. After all, if 3% of people in these high-burden communities who've been exposed to contacts have active TB, we only have to visit about 5 or 6 households to find a case. And surely that's a worthwhile effort to undertake if we can dispatch community health workers, have them collect sputum, carry the sputum back to the health facilities, do the testing, and then we set up a system to send automated text messages to tell people whether they should come back to the health facility or whether they had screened negative. Unfortunately, when we designed a household cluster randomized trial and ran that study, we found that only 20% of people completed evaluation. So a little bit better than baseline, 20% is better than 15%, but it was quite disappointing. And some of the reasons were that many household contacts didn't know how to produce sputum, even when they're instructed to do so. Many community health workers were uncomfortable carrying sputum back. A lot of times they would do visits in evenings in households. They'd have to carry the sputums back to their own homes before delivering it to the clinics the next day. The text messaging system didn't seem to reach people in an era when there were a lot of changes and people starting to use social media rather than text messaging to communicate. A lot of hidden costs of doing this, and people just simply ignored the SMS. In terms of integrating HIV testing, only about 50% of people accepted integration of household HIV testing. And as a result of this, there was really a lot of stigma and persistent health system distrust. The only kind of bright side of this whole story, and this was very disappointing to the team that worked hard for a number of years to put this together, is that the community health worker intervention really seemed to be a very positive step. There was a lot of trust among community health workers, appreciation of the services they were provided, and the community health workers also had a big impact, not just when they were in the community, but also back in terms of improving the services that were being delivered at the health facilities, supporting people with active TB disease, and improving some of the challenges that I mentioned earlier. So, after these disappointing results, we kind of had to go back to the drawing board and say, okay, what is something we can build on? The community health workers is obviously one thing. And the problem that we need to solve is we need to figure out a better way to collect sputum from folks. We need to figure out a better way of communicating these results in this text messaging system. And we need to overall try to engage both household members and the people that are delivering this, the community health workers themselves, to make sure that we can do a better job. And the idea that we thought of is something called human-centered design. So in a collaboration between UTURC, Uganda TB Implementation Research Consortium, and adeo.org, which is a nonprofit design studio, which is based in California, but has offices all over the world and is known, the parent company is known for having created a lot of signature interventions, including the mouse. We tried to look at the problem of delivering TB contact investigation, not as a public health problem per se, but as a service delivery problem. So human-centered design is a problem-solving approach that starts with the people that we're designing for. And so you can see the cartoon here of a Ugandan community thinking and placing ourselves in that community. And what our goal is to try to develop solutions that are tailored to support the community and emphasize building trust and empathy for the people that we're designing for by generating lots of ideas and, importantly, running multiple small experiments to see what works and what doesn't work. And so over about an 18-month process that was a period which was extended a little bit because of the arrival of COVID and COVID lockdowns, we undertook first a period of design research. So rather than starting with a protocol that we developed around the table and implementing it and see what happens, we engaged with the community. We did this process of ideation and rapid prototyping, and then we implemented and optimized between March 20 and March 2021 in order to come up with a final solution that we plan to test in a cluster randomized trial. So what were some of the insights that we gained from this process of human-centered design? Well, first of all, it's kind of a fun process, very different than your typical writing of a study protocol or writing of a grant or planning public health implementation. We engaged a lot of folks, including community health workers. This is the director of the Uganda National TB Program. We kind of marched out into communities. The design team that worked with us used a lot of techniques that are borrowed from qualitative methods and even other kind of more creative approaches, including focus group discussions, observations, some games to try to really elicit what people's preferences were, and observations of their behavior to try to see what activities could help springboard new ideas. And any of you who've been involved with human-centered design before know that one of the most critical things you need are Post-it notes and a big wall to put them on. The Post-it notes are used to write down ideas and move them around to try to find patterns that can be helpful. As a result of this, we kind of came up with 4 key insights. We thought of these insights as ways to kind of help organize our public health intervention. And the first one, as a clinician, this should have been obvious to me, but sometimes we don't kind of articulate this as our goal, as our mission statement. And that is that a TB patient's experience or a person with TB's experience is fraught with fear and anxiety, which kind of chips away at their emotional reserve. And I think this is true of TB, but it's true of many diseases. And actually, the point of diagnosis when we're asking you to do the most is probably the point that you feel at your lowest, because now you know what the cause is. There's a lot of fear and kind of uncertainty about what that means. And that's the point of which all of a sudden you're supposed to tell a public health person who everyone in the world your workplace contacts, your home contacts, or the idea that they're going to call them and let them know either directly or indirectly that you have TB. And so in the words of one of the patients, that first day I was diagnosed, I was so angry, I couldn't even think about speaking to anyone. Second, once we move out of the diagnosis phase, which happens in the clinic, we move to the home. And then the focus shifts from the person with TB to the contact. And that kind of feels pretty uncomfortable and jarring because the family members didn't know that they were going to be subject and going to be told now that they have a risk of developing the disease. A lot of times people aren't aware of how TB is transmitted. And in addition, contacts have other responsibilities. When an index patient becomes sick, if that's the breadwinner in the household, now there's financial concerns because that person can't work. If the person's really sick, they may be worried about them. Certainly being a caregiver, we all know is difficult. And all that is sort of likely to kind of diminish their care-seeking behaviors. And in the words of one of the contacts, even when I'm at work, my thoughts are always on the patient. The third main insight is that the health system keeps layering on demands of us, making it harder for patients and contacts to complete their journey. So in the words of this patient, this contact, at the clinic, there are long lines and most can only be there for 1 hour. Some will fear losing their jobs, so we'll just keep buying tablets at the pharmacy to try to treat a cough. And the fourth major insight was that the success of contact tracing rests on the shoulders of these community health workers. Most of them are going above and beyond. They're not really being compensated. They're being provided money to transport themselves from their home to work. Maybe they're getting a little bit money they can use to buy a lunch while they're outside the home. But largely they're doing this because of the service that they can offer to their community and the respect that they win because of that. So having the community health worker come visit from home gives me energy and encourages me a lot. So on the basis of these 4 insights, we came up with some opportunities for design. And those opportunities were areas that were most likely to impact the contact person's experience. We brainstormed with the designers about different models of delivering services that could confirm these design opportunities, help us find promising ideas, and then kind of evolve those over time. And it's actually interesting how designers recommend going about this. If you want to build a prototype, you don't actually want to build a high fidelity prototype. You want to build something out of cardboard. And the reason for that is because it makes it really easy to criticize. That's actually what you want. You want the person to tell you what they like about it, what they don't like about it. You want them to pick it up, play with it. You can design ways of doing it. So there can be some verisimilitude to that. But ultimately, you're really watching the interaction to kind of figure out which direction you want to go and what activities you can kind of pursue further. And as a result of that, we kind of saw 3 main opportunities for improvement. Thinking about not as a diagnostic process, but more as a journey from home, from the community, from the clinic to the community and back to the clinic. And the first is to kind of invigorate the perceived value of contact tracing. And prototypes that were tested showed that new messaging and value proposition cards can give a more kind of delightful home visit. This was one potential idea. The second opportunity was to try to fortify the process with touch points. And you can kind of see some of the language of the designers creeping in, which was fun. Sometimes we didn't know what they were talking about, but over time we learned their way of talking and some of the value of changing this perspective, right? From what we do in public health, which is often to kind of offer supply. We're going to supply all these services to try to figure out how can we make people not just accept these, but actually want them. So some of the prototypes there were involving peer educators or navigators and customizing plans. And then third was to try to create easy access pathways for contacts, making it easier for them to be transported to clinics. So after all this work, we came up with kind of 3 key points of our new approach. The first was a branding. And the idea behind the branding was to give an encouraging message and also help patients in a very simple way that they're interacting with multiple people in multiple settings, and they don't know how those 2 individuals are related or multiple individuals are related. So a subtle brand was kind of a way of saying, this is a person you can trust. They're representing the TB program. They're branded in a way that your neighborhood community members, they have no idea what this is. Maybe they think it's a food delivery plan. But because you've been told that this is actually kind of a welcoming and supportive. And the name that was chosen, Tuli Wamunawe, means we are together with you. It's a kind of a common phrase that people would say in Uganda, kind of emphasizing this notion of peer support. Second was simple visual materials. This one surprised me the most because there's lots of printed materials in global health. Most of them really don't do much at all. But the way that this one was set up, it was very simple. It was not text heavy. And it actually has turned out to be a great prop for individuals to disclose their status as a TB person with TB to other members of the household and explain that it's curable, how it's transmitted, dispel a lot of myths about that it can be transmitted by sharing food and so forth. So that's been kind of very key for getting index patients to accept contact tracing. And the third is efficient transport for patients and providers. And so this system, now we take the key steps from clinic to community and back to clinic, and we layer onto them this 101 booklet, a procedure to better identify contacts, not just in the household, but outside the household. We recognized that that was necessary to make sure that people in a moment of stress could identify everyone who might have been exposed to them. A simple video to teach them how to collect sputum, which you remember before was a big problem with a previous trial, a referral card for HIV testing, and then these community health riders to collect sputum and transport it to the clinic. We also did a lot of work on training, kind of improving the training materials, adding in videos that were done by community health workers, kind of sharing some of their kind of key lessons for other community health workers. And then finally, in addition to these tools designed to improve the kind of workflow or patient experience, we use something called the community of practice meeting to kind of facilitate implementation that includes several components, specifically audit and feedback reports on performance to help people know when they had failed to complete an activity of screening or visiting a household or following up on a sputum result or giving a sputum, or getting someone started on treatment. And also to allow the community health workers working in this project, a very stressful job, to support one another, to share strategies. We've kind of heard lots of stories where someone had a problem, let's say where a particular person in the community wouldn't allow the community health worker to come to the home, wouldn't come to the clinic to produce sputum. And by working together with other people, they come up with strategies to be able to do that. In one particular case, they said, well, that individual is my neighbor, I'll go and take care of it. So now I'll kind of conclude maybe the last 5 or 10 minutes by describing the study that we undertook, some of the initial data, and giving you a perspective on how you design a trial to actually evaluate something that has so many different components and is really kind of very adaptable to the local context. So our study aims to evaluate the implementation, effectiveness, and public health impact of this, what I'll call not a human-centered, but a user-centered, same kind of idea, strategy as compared to the traditional strategy. So the standard strategy for introducing contact investigation is to organize a training that lasts several days, typically at a hotel, to introduce the guidelines and all the things that would be done. And then to provide supportive supervision in the form of an experienced supervisor who would meet with community health workers periodically and answer any questions, kind of help them do their job. We wanted to layer on top of that these implementation tools that I've just shown and this community of practice, each of which is designed to address a different aspect of the contact investigation cascade and compare them in a step wedge cluster randomized trial. We also planned after the trial to evaluate the processes and contextual factors that explain the success or failure of this kind of novel strategy. Because if it works, you want to know why, so you can replicate it and which parts don't need to be carried forward. And if it doesn't work, you don't want to say it doesn't work, as was the case in some of the 4 negative trials that I mentioned, randomized trials of TB contact investigation, but to know why it actually didn't work. And then, of course, to compare the cost and epidemiological impact. So standard TB contact investigation, I think it's probably clear from what I've said so far, involves inviting new patients, screening them, collecting sputum for gene expert, and then linking those contacts to treatment and prevention. Again, here are some of the tools that I've already sort of talked about. And here's the design of the stepwise trial. So we chose 12 communities in Uganda where there was a high burden of tuberculosis, so that we could be adequately powered to recruit enough participants in the study to understand the difference between the standard strategy, which is being rolled out in these white boxes, and the user-centered strategy in the gray boxes. And those black squares that you see are steps. They're 8-week periods where training happens. The advantage of a step wedge design, as many of you probably know, is that it allows you to have one training team that can move from site to site to site, really spend an intensive period of time getting people up to speed on using all these tools, and then to go to the next site. And you don't analyze the period of time during that 8 weeks because people are getting up to speed and learning how to do things. And you want to get a comparison between the before and after. And the other advantage of this has been reported to be that by doing this, it actually is more statistically efficient than a parallel cluster randomized trial, which might require maybe double the number of sites. And the other thing is that everybody, or at least every clinic, maybe not every patient, but every clinic will eventually in the trial get access to the intervention. So you don't feel like you're withholding something that you would be doing anyway. The interesting thing that happened was that in this particular study, we had an Ebola outbreak in the orange period, and the green period is the holiday period where many people don't come to health facilities. So we originally had planned to kind of pause the trial during that green period, but we had to extend that for a total of about 20 weeks in the middle of the trial when no enrollment was happening while this public health emergency was going on. Here's the randomization ceremony. So you randomly choose which sites are going to be in each step, and we put 2 sites in each step. We had one large volume site, one small volume site. These were randomly chosen and paired together because they were working together in the community of practice meetings. The order of crossover was also randomized because you want to make sure that there are no imbalances between the sites. I'll skip over that and then say that this was a hybrid effectiveness implementation study where the primary outcome is implementation to try to improve the proportion of people that were evaluated within 60 days of the diagnosis. If you remember, in the previous trial, it was about 20%. So we wanted to try to approach 90%, which is what the WHO recommends that we should target. We also wanted to look at the overall yield or effectiveness. So that's that proportion that I showed you in the systematic review of about 3 to 5% of people in households having active TB. And then also to understand the public health impact in terms of what proportion of all the cases are diagnosed in a month come from contact investigation. If we're putting all of these efforts and resources into that, we want a significant proportion of those individuals to be coming from the households. So I unfortunately can't share the results of the trial because we just got the results in October. I do know the results, and we're going to be submitting them to a conference. And I'll let you kind of judge whether you think what you think the results were. But remember, at baseline, about 20% of people completed household contact investigation. So what you can see is this is a mixture of the intervention arm and the control arm. So from the if you look at over the overall period, about 3/4 of index patients were eligible for contact investigation, and about 80% of them were recruited. Big improvement from what we got in the very first days when we were involved, when 2/3 of people refused to allow us to go to the households. Now we're up to 80%. And then among the contacts in the households, you can see that we identified almost 9,000 contacts, and 90% of them were actually encountered and screened between the before and after period. 98% were eligible, and 99% were screened for TB symptoms. So again, a big improvement at the second phase across all phases of the study. And then here is kind of the key point for our outcomes. And I'll just say quickly that in the blue area at the bottom, you can see that 74% of those completed evaluation. That's a mixture of the usual care arm and the user-centered arm, the implementation strategy. So again, a big improvement from what we saw before at 20%, and that the overall yield is about 2.4%. So while I can't tell you the results of the main trial, we have started another study to try to scale up this strategy. And this is funded by the Stop TB Partnership. And it's a collaboration with many of our organizations that I've kind of shared with you before. And the idea here is to do the same things that we did in the original trial, but to go a little bit further, not focus just on finding the cases, but also implementing TB preventive therapy, which I said to you before is a great opportunity of contact investigation, but something that really has not been happening until now. And this is happening in 25 health facilities in 4 districts of Uganda. What you can see here is that while WHO recommends that everybody in these categories should receive TB preventive therapy, outside of people living with HIV, it's pretty poor implementation. Less than half of children under 5 are receiving preventive therapy. And then household contacts over 5, only about 1 in 4. And what we've done here is we've adapted those same materials that I showed before, mainly to kind of introduce the idea of preventive therapy as an additional benefit of contact investigation. And here are just some kind of very rough preliminary results. This study collected preliminary data in March, April, and May, and then beginning in June, began implementing the strategy. And what you can see is that screening and eligibility are pretty similar between the 2 groups, but preventive therapy has increased from 50% at baseline up to 86%. So we're really excited about this because it's going to looks like at this point it shows that there's a big benefit of this strategy also for introducing prevention. So I'll just conclude by saying that I'd like you to take away kind of 3 main messages. First of all, future TB case finding and prevention strategies, must adapt to the fact that many people aren't going to seek care in health facilities. So we need to go and find them where they are, whether they have symptoms or whether they don't have symptoms. If they don't have symptoms, we're going to have to think about how to deploy new diagnostics, whether those are host-based diagnostics, like I shared with you, looking for ways to kind of make those routine, or digital chest radiography and artificial intelligence, which is a very exciting technology that's available. And human-centered design is going to be important to figure out how to do all that stuff without increasing stigma, making people accept these services, and really makes implementation strategies to be user-centered. And implementation trials offer an exciting way of kind of evaluating this in a pragmatic sense to understand not just does the intervention work, but do the strategies that we use to introduce it help to do so as well. I'd like to acknowledge the study team, which had just been outstanding. They did a lot of this work without us on the ground throughout the pandemic to kind of make this trial what it was and what we'll be reporting it to be. My colleague Achilles Katamba, Noah Chiwanuka, who's our biostatistician, and then a number of colleagues at the National TB and Leprosy Program and a number of universities that are part of this, the team from adeo.org, and the National Institutes of Health that funded this through both an R01 and a Fogarty study. So I'll stop there and see if you have any questions.
Open up the floor for questions. I'll bring this over.
Thanks, Luke. That was an awesome talk. Really exciting work that you guys have been doing. I had two questions for you. So first, when the trial ends, like when the implementation study ends, how do you sustain some of these interventions that have proven to be efficacious, or I'm assuming they're going to be proven to be efficacious in some of your study results? Like how do you do that effectively and integrate things into the healthcare system itself? Question one. And then my second question is about community healthcare workers and leveraging the work you've done internationally, domestically, and how we can, I don't know if how much work you've done domestically with community healthcare workers, but how we can sort of conduct public health interventions more effectively in the US using some of the lessons we've learned globally.
Yeah, thank you. Great question, Sandy. So, I think the question of, depending on what the results, how do you go forward? There's a couple different aspects of that. One is, I think, having good local partnerships. And one of the strengths of our collaboration is that my collaborator, Achilles Katamba, has an interesting background in that for almost 20 years before he became a faculty member, he was on the other side, working as a public health implementer. He was the zonal supervisor for TB. And he really understands these issues and has enabled us to have a good partnership with the National TB program. So several of those members are part of the steering committee, and we've been presenting them all on the way our strategy. And so, thinking about how to take this forward, the TB Reach grant that I described to you is sort of one model for doing that. The big problem is that there aren't enough resources that countries have committed to this. And Uganda, unfortunately, is one of those countries. So in September, we had this second UN high-level meeting. And it's kind of interesting for those of us as researchers trying to understand this world, where political engagement is so important, but, people strongly feel based on the experience of HIV that it's essential to get, beyond just the kind of health space to get funding from other ministries. And we can really see from, a lot of the points that I made today that TB is affecting not just health, it's affecting economic productivity, it's affecting child development. There's many, many factors. So the resources are the problem. And this is expensive work to do. We're going to be doing a formal cost effectiveness analysis. We actually have done it for our prior studies. We even did just kind of looking at this human-centered design approach, because a lot of people, I think, fairly roll their eyes and say, oh, you're hiring consultants from California to come to Uganda to do this work. We really looked at it as an opportunity to understand they're the best people in the world at doing it, that they could teach us how to do it. And so we could figure out how to train people, ideally getting designers into the National TB program. So what those cost effectiveness analyses have shown is that it's very expensive startup costs. But if you can scale this to a large number of clinics, even not the whole nation, but in a region, it becomes very, very reasonable to invest in. So it's really, I think, it's one thing is it cost effective, and others is it affordable, right? How do you get the resources to do it? And then just more briefly, I know it went on a little bit long, but in terms of the US, it's kind of interesting. in the middle of this study, when COVID happened, many of the members of our team, including a really fantastic MD PhD student, Tyler Shelby, his work was not able to go forward. So he switched from contact investigation in Uganda to contact investigation in New Haven, focused on COVID-19. And I really saw how we're way behind in terms of, this idea of community health workers. And I think it's really same problem in that, if you're going to involve people, you need to find the resources to pay them, but they can have a big impact. And I think there are some cities, particularly Penn is doing a lot of great work. They have a great implementation science program. Some of you remember Meet the Prasad Kurlan, who was a resident here and is faculty over there, is doing a lot of implementation science work coming a couple of years ago. And I know that some of their interventions are getting out of the community, thinking about how to use community health workers to improve particularly chronic disease management. Maybe for asthma COPD in New Haven. Mark.
So it seems to me that there are a lot of disciplines with expertise that speak to the kind of work that you're doing, particularly in the social sciences. And I'm wondering, have you had anthropologists and behavioral psychologists, people who are interested in things like advertising, on your team? I mean, because it seems to me there's this whole sort of black box of how to think about how people interpret health and preventive care versus treating disease, and where it fits into cultural assumptions. So curious about where that might fit in.
Great question, Mark. I mean, I think for me, one of the things I've always liked about implementation science is working across the disciplines. And I'd say, before this project, a lot of that was more working with engineers and basic scientists. A lot of my early work was in diagnostics and kind of thinking about how do you take something that, makes sense, proof of principle in the laboratory, or an engineering design. How do you get a form factor that can actually work in low and middle income countries? And, maybe this just kind of speaks to Yale, but shortly after I arrived here, I was going to a conference, standing in line to get lunch, and a woman right behind me introduced herself. She's a sociologist who was on sabbatical here at Yale doing a public health in our advanced public health program. And we got to talking, and she had a lot of interest in global health. She became a research scientist with me. She changed her career to public health. She's now a faculty member at NYU. And she's really the one who's responsible for all the qualitative work that I present. I actually didn't present that much today, but we've done a lot of qualitative work that's been very valuable. And I think it is really essential. We also have Ugandan social scientists who we've worked with. And it's very interesting to kind of just get different perspectives, because obviously there's a cultural, element as well that these designs have to kind of take into account. And I think we have a lot to learn. We have a long way to go. I mean, I think global health in general is re-examining kind of how these collaborations work. But we learn a lot from each other, and it makes it a lot of fun. And I think it's one of the factors that led to the progress that we're making in terms of our intervention.
Is this on? It is. Okay. Thank you so much. It was really exciting to learn about what you do all the way in Uganda. And I wanted to make a comment, and then I had a question. My comment was just the appreciation of working with community health workers. I think that's always the answer when you are trying to work with vulnerable population of which you are not a member of. I think engaging with the community is absolutely like the right answer. And so I'm so glad that was the main takeaway from your initial study. And so I imagine that I hope there'll be more success there. And I also wish that there was more compensation and appreciation for them aside from just the community's appreciation, but I wish that they were valued more. I know that's not something that you're in charge of. My question was, I don't know if you addressed this at the very beginning because I missed the first few minutes of your talk, but I know that your research is focused a lot on the diagnosis of the case finding and sort of what barriers, there's certainly a lot of barriers related to that, and going to the homes and doing this implementation seems to be a really good strategy. But what has been the information in terms of who's paying for the treatment? Is that a barrier, and how compliant are patients with treatment? And is that a barrier as well to, successfully eradicating TB? As that being a long-term goal, is diagnosis our main obstacle, or are there treatment barriers as well?
Well, in general, diagnosis, I think in improving prevention, we obviously don't have a TB vaccine that's very effective, although there's been a lot of progress on that. And I think a few years back, we had, talked about some of those trials. And so that'll be something to keep an eye on over the next few years, especially with mRNA vaccines and so forth. But we have highly effective treatments. The problem with treatments is that they're long, but they're getting shorter. There's now a 4-month regimen. There's even a 2-month regimen in certain situations. So I think diagnostics is really the most important thing. And I talked a little bit, probably just before you got here, about this idea of catastrophic costs and how, free TB services are free when you get there. You don't have to pay, for any of the clinical services or the tests or the X-ray or the medications. All of that's free, yet it's a very impoverishing process. And so because of the backgrounds that people are coming from, because of the way the diagnostic process is organized, multiple visits, multiple days, we've really worked a lot to try to streamline, to think better about how do you make that process more, again, user-centered. We had a paper that was published in the New England Journal that showed, I was not the lead author, but our team, Achilles was the lead author of that one, sort of showing that type of approach can make a big impact, about a 70% increase in the number of people diagnosis starting on treatment. But I think people are also working on social support, meaning finding ways to use the social services system to pay people, when they get diagnosed with TB, to enable them to kind of be able to go through the process. And it's difficult to organize that effectively. Many governments don't want to consider that, but there's a lot of promising evidence that that may be a strategy through vouchers or whatever other means. So yeah, no, you're absolutely right.
So there's a lot of really great comments in the chat box. I think we just have time for perhaps one more question. So this is one from Kathleen Atkin. What is your sense of how widely this can be scaled up? It seems like it requires so much person power to get it and keep it the appropriate stakeholders invested.
Should I speak into there? Maybe they can probably hear me over here. So yeah, no, it's a great question, Kathleen. I think I mentioned at the end of the talk, we're kind of evaluating a lighter version of this, which is being done kind of with fewer resources at a larger scale. So we're gonna need to figure out which components are necessary and which aren't. And one of the ways that we're thinking of doing that is their novel adaptive designs and trials. One of the best known is called a MOST trial, multi-phase optimization trial, where you can take the different conditions and test them sequentially and design the trial in a way that it's powered to efficiently answer that question. So I think we all saw the power of adaptive trials during COVID for understanding the impact of different interventions. So we're thinking about how to do that as our next phase, and hopefully, only include the interventions that are most necessary, that are making the biggest difference. But ultimately, kind of going back to Sandy's question, I think governments are going to have to recognize as a priority. One of my colleagues is probably a good note to end on in Uganda. Moses Jaloba always says, he said, in TB, they always want to get things for free. And you really can't get good outcomes if you don't make an investment. But this is a curable disease, and the goal of the TB community is to eliminate TB, meaning eliminate it as a public health problem in our lifetime. And if we're going to do that, we're going to need more commitments from governments and public health programs, and also better strategies and better tools. So thank you very much.